So we are going to move to the next panel, panel number 6. So I would like to invite the moderator and the speaker and the panelists to come up. In the meantime, I would like to tell you that I'm from AIDS Healthcare Foundation, and we were honored by IAPAC by inviting us this year to be co-sponsors of this Treatment as Prevention Summit. And by saying that, I would like to introduce James Rooney from Gilead Sciences, who's going to be the moderator, as well as the Kenneth Mayer, who's going to be the main speaker on this panel, and then Ronnie will introduce the rest of the discussants here. Kenneth Mayer is from Harvard University, a professor from Harvard University, and the head of the Fenway Clinic in Boston. Thank you.
Good morning, everyone. So I'm going to be just doing an overview of PrEP as it is. We have several sessions this morning that will be discussing PrEP, and it's important for us to think about this in the context of using antiretrovirals for prevention. If I could have the first slide, please. Thank you. So the data are very clear. PrEP works if you take it. So this slide is developed by Slim Karim. And you can see almost a linear relationship of the most successful studies that were associated with the highest levels of adherence. So the discussion is not about whether PrEP works, it's how to operationalize it in the real world and what is its role as part of a menu of prevention interventions that we have. So there are a host of different questions that we continue to have. And the early pivotal studies really do provide a good deal of answers. Symptoms. We know that for a small number of people, there is a startup syndrome, most usually associated with GI side effects, which tends to be self-limited. In the major studies, this was under 5% prevalence. We know that tenofovir can be nephrotoxic. In all of these studies, there was careful renal monitoring, and there was not any significant level of substantial renal impairment. So again, we know that if we monitor people, certainly people with suboptimal creatinine clearances should not be initiated on this particular medication. And there are other studies, and Cheryl Zworski will be talking about some of the current trials looking at other antiretrovirals. The issue of bone, this was not a clinically significant finding in terms of bone mineral density loss, very similar to people living with HIV. Tenofovir can be associated early on with some bone mineral loss. There are 2 studies now in the Adolescent Trials Network because we know that bone continues to form in late adolescence and early adulthood. So these studies are following youth as early as age 15 and as high as 22 years old prospectively. They include DEXA scanning. But there's not been any safety signal. These are Data Safety Monitoring Board followed trials. And the first Adolescent Trials Network study has been going on for more than a year, and there's been no signal to suggest stopping. So we don't have worry there. Selection for resistance, again, in the controlled environment of the clinical trials, there's been very little evolution of resistance. But even as PrEP has been rolled out, very little resistance has been selected for. Almost never the K65R, tenofovir resistance. The 184V has been the type of resistance, but we are in the cusp of going from efficacy studies with tight monitoring to effectiveness research, but certainly no safety signal in this regard at this point in time. Risk compensation, I think, is a misnomer. People who go into these studies or people who, outside of studies who elect to initiate PrEP are individuals who have some substantial risk of becoming HIV infected. So what the study suggests is that not that people increase risky behavior, but people maintain behaviors that might put themselves at risk. But by using chemoprophylaxis, they are now protecting themselves against HIV. We clearly have to monitor for other sexually transmitted infections. In IPREX, for example, we had very high rates of syphilis prevalence and syphilis incidence. So clearly, PrEP has to be seen as part of a sexual health package, and part of that sexual health package is screening for treatable STIs. There's still the question about to what extent do some of the different prophylactic regimens protect against herpes simplex virus type 2. The strongest beneficial effect was seen in the Caprisa 004 study, and it'll be very interesting to see if in the FACS study of gel or if, future studies in the microbicide trials network of rectal gel, whether we can see a herpes protective effect when you have very high concentrations of tenofovir in mucosal surfaces. And there are other approaches underway, and we will hear more from Charles Worski, but certainly over the next year, chemoprophylaxis may be transformed as ring studies and as the third topical vaginal gel study mature and when we see those data. There are many people now on chemoprophylaxis in the context of controlled studies. So there are more than 25,000 individuals who are the key populations who are participating or soon to be participating in some of the demonstration projects and the effectiveness studies as opposed to the efficacy trials. So the early lessons from the demonstration projects are that individuals who self-select to use medication tend to be quite adherent. So many people have been concerned that in several of the efficacy studies, such as in the VOICE study, there was no efficacy seen because of low levels of adherence. And this is a concern, but in a clinical trial, as somebody who's been involved in a number of PrEP trials, the informed consent only a lawyer could love. I mean, the informed consent said you have a 50-50 chance of getting something that's a placebo, and if you get the active medication, it may not work and it may actually cause you harm. Now that we have data that says that this does work and it doesn't cause you harm if you use this in a consistent manner under careful clinical monitoring. Individuals in the San Francisco demonstration project, which was conducted in conjunction with colleagues in Washington, D.C. and Miami, there were high levels of tenofovir in the blood, and some of the other early demonstration data suggests the same thing, that the majority of individuals are taking some of the medication. The question then gets into how parsimonious can you be in terms of your dosing of the medication, but certainly the early signals suggest people who elect to start PrEP may be likely to be adherent. We looked at the data in the IPREX open label study as well, and again it was reassuring in the sense that individuals who tended to engage in condomless sex were more likely to have drug detected in the blood. Individuals who had more partners were more likely to have drug detected in the blood. These are individuals who we want to have drug detected in the blood because they have some substantial risk of becoming HIV infected. Certainly one concern is that IPREX, which had a very geographically and socioeconomically diverse population, people who were younger and people who were likely to be poor because of lower levels of education, were less adherent. And clearly this is the challenge for us to develop messages that will enhance adherence in all the key populations. There's been a very robust discussion in the blogosphere, and Jim Pickett's going to talk more about some of the interactions, but I just want to call out one resource I think is very important. The AIDS Foundation of Chicago has put up web testimonials. These are not paid adverts. These are individuals who are using PrEP on their own volition, log in, share their videos, which are stories that other individuals can listen to and get a sense of what it feels like to be beyond PrEP. In addition, there's a tremendous need to educate providers. At Fenway Health, we've put together a number of materials which, again, are available on the web for consumers and particularly for providers, because we clearly know that providers need a good deal of education in this area. We've tended to survey the internet serial surveys. So the most recent survey that we conducted in early 2014, the data were presented at CROI, and the aggregate prevalence of PrEP use among the individuals, again, not a population-based survey, but a convenience sample. About 1.2% of the respondents on Manhunt, one of the more popular MSM social networking sites in the U.S. and globally, about 1.2% overall prevalence of PrEP use. A lot of individuals still had not heard of PrEP. And a lot of the individuals on the site had not heard of post-exposure prophylaxis either, which is very concerning. One of the other concerning things is when we did the multivariable analysis to look at who actually had used PrEP, we found one of the key factors, and this was alluded to yesterday, if people were not comfortable talking to their providers about their sexuality, they were less likely to be using PrEP. So clearly, again, part of our challenge is not just educating communities at risk, but really working with providers to create safe environments where sexual risk can be discussed and where this new modality may be considered. At Fenway, we've been working on development of tools that help people adhere better to PrEP, so through funding from the National Institute of Mental Health. With my colleague Steve Safford, we've developed an interface that both involves individual counseling and also web check-ins so that we can record as individuals are risky on a given day, and also send them text reminders about taking the medication. Another approach, which Raphael Landovitz and Revea Miko have developed in Southern California, is an active, ongoing study that's a staged study so that all participants get an initial level of an intervention, and then drug levels are assessed. And individuals who have lower drug levels then receive additional next step counseling so that not everybody needs the same intervention. A little sticky this morning. We also have to think about key populations are not homogeneous. So within this whole rubric of key populations, for example, if you talk about men who have sex with men in the U.S., we have incredible economic disparities between black men who have sex with men and other men who have sex with men, and a disproportionate share of the epidemic because of assortative mixing. In other words, people tending to have partners within the community. So recently, the HIV Prevention Trials Network sponsored a study which followed a cohort of about 1,500 black MSM and found very high incidence, but also found that HIV incidence and prevalence was associated with unmet social needs, poverty, and history of incarceration. So PrEP alone is not going to be a panacea in this setting. So Dr. Sheldon Fields is the protocol co-chair and is with us today, and Dr. Darrell Wheeler is the chair of a demonstration project focusing on black men who have sex with men, with trying to culturally tailor the delivery of PrEP. Additionally, we know that the epidemic is disproportionately affecting youth. So other interventions really have to be very youth-focused. So Sybil Hosick in Chicago has developed a suite of interventions which are being studied in the Adolescent Trials Network, and finding that a youth-tailored intervention can be associated with higher uptake and adherence to PrEP. But providers are clearly a challenge. Doug Krakauer is a young physician, a very interested in provider-patient communication, has been studying providers in New England and came up with the term the purview paradox, basically that infectious disease specialists say, I don't take care of HIV uninfected individuals, so I'm not used to all this counseling. And generalists say, I'm not used to using all these antiretroviral medications. This should be the purview of a specialist. So the future is challenging. Doug identified a variety of different barriers that providers had for why they were not initiating PrEP or having conversations around prevention. But we think that the future may be to use heuristics and to be able to use algorithms with our social media. So Dawn Smith, project officer at the CDC, developed a series of questions, and that could give a numerical response, and that might be a decision tool to help clinicians decide whether somebody might benefit from PrEP or not. At Fenway, we routinely offer HIV-infected patients patient-reported outcomes. So in other words, these are tablet PC interfaces that people can be asked questions while they're in the waiting room. They can be delivered electronically to a person's medical record. These kinds of tools could even be filled out at home online. So I think that this may be a future to be able to facilitate ongoing conversations with taking less time in the clinical visit and needs further explanation. Another concern that many have expressed is that PrEP is not cost beneficial, that is such that the medications, even in international settings where there's lower costs for antiretrovirals, it's much too expensive. This curve, developed by David Glidden, the protocol statistician in IPREX, and written up by Susan Bookbinder, plots the efficacy estimates of the different chemoprophylaxis prevention interventions, and also plots it in reference to the incidence. And so you can see, for example, in the red, the Caprisa at the bottom, that the number needed to treat, the number of women needing to take a year's course of medication to protect, to prevent at least one new HIV infection is in the 20s. And the reason for that is not that Caprice had such a strong signal. Remember, it was 38% protection, but HIV incidence was so high that doing nothing meant that you'd have 9% of the women in the placebo group or a non-intervention group becoming HIV infected. So even a modest protective effect can be highly beneficial in areas of high incidence. Conversely, the Bangkok IDU study found that it was protective at a similar level in the 40s, but incidence was so low in that setting, about 0.5% per year, the number needed to treat was exceedingly high. You can see that, for example, for MSM with close to 4% incidence, that about 60 individuals needed to be treated for a year to prevent an individual against one infection. If you're talking about 60 individuals lifelong, that's a lot of drug to protect one infection. If you're talking about people using medication during periods of risk, this actually can be quite cost beneficial. And it's also a question as a society, why do we privilege? So David Glynn has a good sense of humor as well. So, for example, currently we think nothing of having people take statins to prevent cardiovascular or cerebrovascular events, but it's 250 individuals on statins to protect against one of these bad events. So number needed to treat is an important metric to keep in mind about the different issues. And cost benefit is something we should discuss more, but certainly there have been several analyses now suggesting in high incidence areas chemoprophylaxis is cost beneficial. And the cost of the medication, as we know, is going down globally. So we should think about additional cascades. We've been talking about a treatment cascade. Al Liu at the San Francisco Health Department has talked about a PrEP cascade. And if we try to put this all together, I think of it less as a cascade and more as a kind of servo mechanism. So the ultimate goal is getting people tested. If people test negative, it's not that everybody needs PrEP, it's that we have to have the tools to screen those individuals who may benefit from PrEP. If people test positive, we obviously have to get people engaged in all the different aspects that we currently refer to as the cascade. But we can't lose sight of the reasons why people may be at particularly high risk for HIV or not do well when they're in care. And those may deal with intimate partner violence, other relationship dynamic issues, behavioral health issues, and substance use. And we have to attend to these issues, the socioeconomic and behavioral issues that are confronting individuals if we're going to get it right. So PrEP in 2014, we have proof of concept. We have a long way to go in terms of optimization, and look forward to the discussion. Thank you.
Thank you very much, Ken. Our next discussant is Dr. Richard Gilson from University College London.
Thanks very much. I think we've heard a lot about the various aspects of treatment as prevention, and obviously what we're now talking about is PrEP. And I think from our perspective here in the UK and as an investigator on the PROUD trial, I think it's important that we think about the role of pre-exposure prophylaxis in this whole spectrum. And I think our perspective on this is very much that PrEP has a role to play, and we think that it is important that we should test this out and see how it fits into the combination. And we need to think about combinations not only sort of cross-sectionally in the sense of multiple components of prevention at a population, but also at an individual level. So increasingly, with our experience in the PROUD trial, we've seen that for an individual, PrEP may well be a useful component at some point in their life or in their relationships or whatever it is. There are times when PrEP may be a very important potential component of prevention strategy. But it won't fit everybody, and it won't suit everybody for the whole duration of their sexual life. So what we're doing here in the UK in the PROUD study, which I think fits in with the discussion that we've had, is to move on from studies of efficacy, which has been well demonstrated, to effectiveness, to see whether how effective this strategy could be, which is why we designed the PROUD study as an open study, not a placebo-controlled trial, as virtually all of the others have been. And so this is an open study of offering participants immediate PrEP or deferring those individuals for 12 months, so the individuals know perfectly well whether they're taking PrEP or not, and what we're able to then see is, well, do they actually take it, and what happens to their sexual behavior, and how does that compare with the group who have agreed as part of the randomization to defer it. So we hope that this will contribute to the data that we need to move this on. And the situation at the moment with the PROUD trial is that we've completed a pilot and are going to move on, and we hope, to the main trial, but there is a hiatus while we agree funding for the main trial. But we've recruited 550 individuals, which has certainly demonstrated that it is possible to recruit individuals to this sort of study. We've demonstrated that that individuals will take PrEP under these circumstances. We now need the power of another 1,200 participants in order to prove our primary endpoint.
Thank you very much, Richard. Our next discussant is Beatrice Grinstein from Rio de Janeiro.
Thanks, you, Jim. Thanks for the invitation to participate in this discussion. It's really very important for our country to be participating in this discussion, and I will focus my discussion points from the perspective of a middle-income country where, as you heard yesterday, universal access to health care is provided by the government. We have adopted the test and treat strategy, and we not only provide antiretrovirals but also monitoring. And from a couple of years also, NPEP is already available through the public health system. So in this context, we see that the major overarching concern in regards to PrEP implementation is the very low level of research literacy and knowledge about study results showing that PrEP is efficacious. And this is true not only for the MSM community, but also, and very importantly, for the healthcare providers. And these characteristics may, at the end, result in low demand for PrEP and also barriers for those who come to the services to ask for PrEP if it becomes available in the future. So as healthcare providers are gatekeepers for access to PrEP and also to PEP, this really has an impact. And as I mentioned, and although PEP has been available for the last 4 years, the uptake has been low, although in continuous rise. So community education is a major issue for us to go for, and as well as provision of education for healthcare providers. Another major point is how best to deliver PrEP for MSM and trans in a context where stigma and discrimination against these populations prevails in the majority of health services. So it's very unlikely that in our context PrEP will be delivered if it becomes available outside of the healthcare services due to the characteristics of our system. So it's very important that we figure out how best to offer it. And as we envision it today, it would be very important in our context, to establish referral services for to have these sexual health services provided, not only limited to PrEP, but using it also as a great opportunity to offer, to expand HIV testing, NPEP, STD testing, hepatitis screening, and vaccination. So we have opened our demonstration project a couple of months ago, and this demonstration project aims to enroll up to around 500 MSM and trans, and it's being conducted in Rio de Janeiro and São Paulo, and it will be expanded to Porto Alegre in the south very soon. This project is all funded by our federal government with drug donated by Gilead, and it will be a really important opportunity for us to better understand how best to deliver PrEP in our environment. And so far, to put together this project, we have organized an expanded access to HIV testing, and with data that we got yesterday, we already assessed 403 individuals for this expanded testing program, and 93% of them MSM. Only 5% of trans. It has been more difficult to have access to trans, and as you all know, it's also more difficult to enroll trans and to make them aware of PrEP benefits and to bring them to this type of study as well. And from all those 400 tested in the last couple of months, 50% of them have heard about PrEP. And very interestingly, 80% of them understand that PrEP can have protection for them, and 80% of these 400 tested showed a very high level of interest of using PrEP for their protection, plus 14% having some interest. And this would be if PrEP would be available through our public health system. However, 74% would be willing to pay, if needed, to have PrEP. There were also important comments about dropping condom use, and 60% disagree completely that they would leave not using condoms, so the majority would keep condom use as well. So these are interesting information for us to understand how best to frame and discuss PrEP in our context. And importantly also, we understand that to adequately frame PrEP program, it should be not only pointing out for an individual benefit, but also as having a public health benefit due to interrupting the transmission chain and contributing to the control of the epidemic. So these would be important points to be added when framing PrEP in PrEP programs for different countries.
Thank you very much, Beatrice. Our next discussant is Andrew Gulick from the Kirby Institute in Sydney, Australia. Andrew.
Thank you, Jim, and thank you to the organisers for the opportunity to speak to you today. So the perspective I come from is certainly from a high-income country, and one where there is government-funded healthcare. Pharmaceuticals are covered by the government, and the payee has only a small co-pay to cover. And also, I think the other important bit of perspective is that I come from a country like most countries where there is not yet formal approval of Truvada for PrEP, which does lead to some difficulties at times. I'll speak to you also as an investigator on some of these demonstration projects in Sydney, Melbourne and Brisbane, but also as a person who's involved in policy setting in the Australian context. So in terms of Australian PrEP studies, like Beatrice, we have studies funded by the study conduct is funded by government and drug provided to us free of charge by Gilead. And those studies are recruiting very well. I think 100 of a total of about 500 total have been recruited in the last couple of months. They've only started recently. And it seems the demand has built a lot over the last year, and there is actually quite a lot of demand. I want to spend most of my time, though, talking about issues of policy formulation, because we're having some real conundrums in Australia in regard to this, and I think it's going to stop us having any major rollout in the near future. The first is the issue of guidelines, and it's been fantastic to have the CDC guidelines as a model in the last few months, I must say. They are, in general, very good. But we are spending a lot of time with the clinicians who are writing these guidelines on the issue of targeting. Who really, in a predominantly MSM epidemic, who should get PrEP? We are concerned that because of the cost of the drug, that this must be very, very targeted. This argument will change completely if the cost of the drug was, 20% of what it is. Then the issues of targeting would be less germane, and Ken, your argument about statins was a good one, but statins don't cost $10,000 a year. So there is a key difference there. So where the clinicians I'm working with want these guidelines to be as evidence-based as humanly possible, so that we're taking data from local cohort studies on relative risk. And this is leading to some quite complex guidelines, and to be frank, I'm not sure that they're going to be terribly pragmatic. So one of our issues is that, based on data from cohort studies in Australia, circumcised men who only put themselves at risk through insertive anal sex are at very low risk of HIV infection. So the guidelines, the current draft of the guidelines says men who only have insertive sex and they're circumcised are not eligible for PrEP. I think that's very hard to implement. Nevertheless, at the other extreme, if you said all men who have unprotected anal intercourse are eligible for PrEP. Now, we know that we have very good data on this, that the great majority of unprotected anal intercourse among gay men are in seroconcordant HIV-negative couples, which poses next to no risk of HIV infection if they're in couples who have an open and honest agreement about sex outside the relationship. Again, we have good data on that, and that it's not at high risk for HIV infection. So I think we have to find somewhere in between those two extremes of any unprotected anal intercourse and those really overly detailed. We're also interested in our demonstration projects looking at issues of periodic use of PrEP, because again, studies of gay men who are recently infected in Australia show that a very large proportion get infected on holidays. They have periods of high risk. They manage to really manage their self-protection with condoms most of the time, but then when they let their hair down, or if they have no hair, let whatever down, they're at high risk. And so that might be a bit like malarial prophylaxis on holidays, for a week before you go away, during your holidays, and for a couple of weeks after you get back. And we're going to be very interested. We're going to allow that sort of use in our demonstration projects. Another issue of guidelines is serodiscordant MSM couples. A lot of our clinicians are still concerned that the evidence of treatment as prevention's effectiveness in MSM is not yet good enough to tell couples where the positive partner is undetectable, that the negative partner does not need PrEP. We have the data from the partner study. It's excellent data, but to the highest risk behaviour, receptive anal sex with ejaculation, there's less than 100 years of person years of follow-up in that very high risk category. So we really need more follow-up through studies like Partner and the Opposites Attract study, which we're doing in Australia and actually in Brazil and Thailand as well. And then I think the thing that will change this all in a couple of years' time is when Truvada comes off patent. Because when this drug no longer costs $10,000, we will have a very, in government-funded healthcare systems, we will have different thresholds for using it. And then I think that would really be a game changer.
Thank you very much, Andrew. And our next discussant is Patrick Oyaro from Family AIDS Care and Education Services Program in Nairobi, Kenya.
All right, thank you for the opportunity to share on behalf of the implementers down there. I come from Kenya, and the last week has been very interesting. There was a publication on the newspaper that Kenya plans to use taxpayers' money, 4 billion shillings, to buy drugs to give sex workers. Now, that is how the headline was. And immediately, people were commenting and asking questions. And I said, this is an opportunity for us to discuss and come to an agreement on this issue. Just this morning, I was listening to radio again back at home online, and the discussion was, what about PrEP? Now, I said this because Kenya, and I know several sub-Saharan African countries, could have adopted the latest WHO guidelines, but there was no mention on PrEP. So for Kenya, for example, we have adopted the latest WHO guidelines. And so we are initiating patients at CD4s of 500 and below, then all HIV-positive discordant partners, HIV-positive partners in discordant relationships are going to be put on ART, irrespective of their CD4. then we've also adopted option B+. So what has not been mentioned is PrEP. And again, so when we go back, what are we going to discuss about it? So this discussion is very important. And based on the previous presentation, I work with SARCH. And so SARCH has been doing treatment as prevention. And at some point, probably after 3 or 5 years, we'll be able to share the results, comparing communities that are giving ART respect, test, and treat versus those who are following the current national guidelines. So I would be able to share that too. The other thing is one of the sites that we work in, that is our headquarters in Kenya, participated in the PrEP study, and right now we're doing what we're calling PrEP demo to try and answer some of these questions that we are asking here. So on an implementation side, I oversee a program that has enrolled 150,000 patients with HIV, and the counties that I support are listed as the core counties that we were discussing yesterday, because we have around 5 counties which bear 75% of the new infections in Kenya. So this is a really high-risk community that needs interventions. So as an implementer, what are the questions? Some of them have been mentioned. We have to identify people before we say that you're eligible for PrEP. We have to know your HIV status. So we go back again to test. We have to identify you. And then the issues of adherence. In the clinic setup, we have structures to assess adherence. How are we going to do this for someone who is taking PrEP? Who is going to prescribe it, and who is going to dispense it? Are we going to dispense it in the health facility? Are we going to dispense it in the pharmacy outside there? Are we going to dispense it where we can find the sex workers and their partners? So these are critical questions that we really need to answer. Communication comes in, because in Kenya and probably several sub-Saharan African countries, it is not out there in the public like in the newspapers or on radio. However, people are reading and they come asking us questions. Instead of using a condom, can I use PrEP? Can I use the drug instead? But it has not been publicized out there. When we decide to publicize it, how are we going to address this? I say this because when we started implementing voluntary medical male circumcision, some people did not get the message right, and so they celebrated after getting the cut, thinking that it was 100%. And we had to tell them, no, you have to use a condom, you have to observe the other prevention strategies. So communication, what are we going to do about it? It's true that condom has been there for many, many years, but the Kenya AIDS Indicator Survey showed that there's still a good proportion of people who don't use condom. So what are we going to do as far as communication is concerned? So for me, again, if I go back to the data that we have, the program data that we have, out of the active patients, the patients who are active on care, right now, about 70% of them are on ART. Now, with the new implementation of the new guidelines, I guess that is going to push another 10 to 15%. Then we are going to just remain with a few people, the active patients who are not on ART. The question is, should we move on and implement a PrEP together with initiation, together with heart for prevention? I think we need to discuss and agree on this. That's what I have to share today.
Patrick, thank you very much. We now have some time for questions for panelists. If you could please come up to the microphone or bring the microphone to you, so everybody will be able to hear your question. Okay.
Thank you. I just want to make a couple of observations as I was listening to the panel. The first is I've never really felt that clinical trial patients represent patients that I see in my office. For a lot of different reasons. They're in a much more controlled setting, whatever. And the compliance in the studies was not very stellar, I would say. And I think compliance in the population is going to be even less stellar. And so we're naive to think that there's going to be no development of resistance on PrEP. And it's going to become a real problem for physicians who who treat patients. That being said, I do have patients on PrEP. I think promoting testimonials about PrEP is a really dangerous place to go. I think this should have been worked out before we even started using PrEP. If you look at gay cruising sites on the internet, people are putting that they're using PrEP in their demographics to say it's okay to have unsafe sex with me because I'm on PrEP. And what nobody on the panel has addressed is, well, what's that going to do to hepatitis C? At least with a condom, there is some protection from hepatitis C. A lot of people are stopped using the condom and now using PrEP instead. And I think that's going to cause a huge increase in hepatitis C. And the last point is, at least in Canada, PrEP is not approved by Health Canada. So when an insurance company is paying for somebody's Truvada, they're going to code them in the medical database as HIV positive, because that's the only reason in Canada to prescribe Truvada. And so does anybody talk to these patients about their potential insurability in the future? Because they may be in a database saying that they're HIV positive because they're taking Truvada. And I doubt very much people have thought of those things. Thank you.
So thank you very much for that comment, and maybe one of the panelists would like to make responses back. I don't know, Ken, do you want to?
Sure. You know, the issue of whether people in clinical trials are representative of people in the real world, I think it can go in both directions. So I don't think we have data that says that people invariably are going to be less adherent, because, again, some of the individuals are presenting because they read about this and want this. And, you know, the onus, again, gets back to clinicians being adequately trained to tell people what you get and what you don't get if you initiate PrEP. And I think they have to explain this as part of a prevention package. In terms of sexual transmission of hepatitis C, the data really suggests very strongly that it is disproportionately among HIV-infected individuals, not that sexual hepatitis C transmission among uninfected individuals doesn't occur. But so I think that is something that a clinician needs to discuss and think about with patients. But certainly the bigger risks are syphilis, gonorrhea, and chlamydia. But again, the important thing is to make it clear to somebody who's thinking about initiating PrEP what are the trade-offs for that individual. And I think our point of view, at least at Fenway Health, is around sexual harm reduction, that we want to make sure that patients are fully educated and that they can make informed choices. We can't tell people what to do, but we have to say that these are the benefits, these are the risks. In terms of the insurance, I only am familiar with the insurance issues in the U.S., but certainly the point you raised about Canadian insurance would be something that the blogosphere should make sure that people understand the risk in that setting.
Yes, additional questions? Bring a microphone. Yes? Okay, sorry.
Thank you. Very briefly question. I would ask the opinion of panelists on an approach of PrEP that was not mentioned, if there is a role for intermittent pericoital provision of antiretroviral drugs for PrEP, as PrEP. And a second point, the opinion on the target of the use of PrEP periconceptional in some discordant couples.
I don't know if any of the panelists wants to address the question. Richard, do you want to give it a shot?
We did, when we were designing the PROUD study, we did spend some time thinking about what the most appropriate intervention should be, and we ended up by going for continuous treatment rather than, or continuous prophylaxis rather than intermittent. But we certainly were thinking about also various strategies about initiating treatment before the weekend, continuing it for 24 hours afterwards. There were a whole variety of possible ways. And our view in the end was that all of these things were probably too complicated, and life would be simpler, and the adherence would be better if you simply said
just take it regularly. But I think the other thing that you reflected on, and has also been reflected from some other comments, was I think it is certainly true that continuous PrEP is not necessarily the best thing ongoing, and there may well be an argument for PrEP around particular times in people's lives or particular times in the year and so forth. There are clearly variations on this.
I think we have time for one more question, perhaps, in the green.
Jim, can I just?
Yeah.
There are 2 studies underway looking at less than daily dosing. So there's the EPERGAY study, which is 2 doses before a person anticipates a risk, and a dose a day for 2 days afterwards. So that study is well underway. And then HP 10067 Project ADAPT is not an efficacy study, but it's looking at the acceptability of fixed interval, the Friday, Monday, if you're going to party over the weekend kind of dosing versus event-level dosing. So we'll have data in the next few years.
Last question, yes.
Thanks for the panel discussion this morning. Kenneth, something that you said that made me think about the issue of criminalization, particularly in the United States, certainly in North America and countries where there is a lot of criminalization of people with HIV. The risk assessment profiles that you're discussing, and even the technologies through which that information is transferred, certainly could leave people very wary, and all of these discussions around risk assessment that we're talking about will leave people very wary of having a very detailed risk profile connected with their medical records, and then something that could be subject to a police search, because in many countries it's about HIV exposure or willful blindness about your potential risk as somebody who could have had HIV. You could be criminalized in those circumstances. So I just wondered if others on the panel too had thought about the interactions between criminal prosecutions, personal risk assessment, and record keeping, because there's certainly evidence from a lot of medical professionals. I'm thinking of Eric Mikulovsky's work in Canada, that they have quite a large concern about openly discussing risk with their patients because they don't want to expose them to the law in this way.
Anyone want to make a comment about that?
The point about PrEP, though, of course, is that the people receiving it are HIV negative, so they're not the people who get prosecuted. So they'd be talking about partners, not themselves. Yeah. So I think it's less of an issue with PrEP. It's a big issue in studies of treatment as prevention. So in our study of treatment as prevention, we collect the information on behaviour from the negative partner and not the positive partner for that very reason, because there is a risk of transmission. If they're collecting it from a negative partner about another person, that's legal hearsay, and you can't convict on person on hearsay.
Richard?
I think the other thing to remember is that this isn't dramatically different from what we do every day in a sexual health clinic. You take a detailed sexual history, and that's part of good sexual health practice, and it's vital that this group, who we know are at risk of other STIs, maintain a situation where they have good sexual health care, and taking a detailed history is absolutely key to that.
Well, with that, thank you very much. We'll thank the panelists for an excellent discussion. So, thanks.